into medical marijuana at this particular conference during the two-day proper session. Tomorrow is an entire day on medical marijuana in all of its different forms, but this looks at the substantive science and the politics behind marijuana, marijuana and health, medical marijuana, and we're blessed that we have a number of distinguished researchers and professors to share their information with us. I've seen a lot of their information in advance, and it's terrific and compelling stuff. A lot of it is, of course, in the materials, and will serve you greatly in the time after the conference. And hopefully we can squeeze some Q&A in, because there's a great panel to put your questions to. So we're going to introduce Mitch Earlywine, who's on NORML's advisory board. And I dare say, I mean, it's kind of a lofty title to, or aspiration to put on anybody, but, you know, again, we speak to the changing of the generations. And there really aren't that many researchers or professors who are as dedicated to telling the truth, the scientific truth about cannabis and its interface with the human body, with the human mind. In essence, I think personally Mitch Earlywine is sort of the next Lester Grinspoon, somebody who is going to risk his tenure everywhere he goes. Now, by the way, you know, Lester Grinspoon never became a full professor at Harvard Medical School after 40 years there, because he took this stand. Now, thankfully, Mitch has procured tenure, I presume. Yes, that head goes on.
I'm up for full this year, so.
Okay. So this gives one academic freedom that few enjoy. So Mitch has a great presentation, and I'm going to open it up to him and thank him for putting this panel together.
I really want to thank you guys for being here. This is our opportunity to really get down and dirty into the real data about some amazing aspects of medical cannabis, but also to, at Paul's request, get a feel for each person's experience about what it's like to do essentially medical marijuana or marijuana-related research. How do you handle the different funding agencies? How do you make it work? How is this going to become what it needs to become in order for us to buttress the arguments we need to make sure the world really changes in the direction we want to see it go? You've heard me talk twice yesterday already, so I just want to jump right to our participants. I'm going to begin with a man who essentially needs no introduction in this crowd, but I just want to say he's clearly the cutting edge of medical marijuana researchers and an inspiration to us all. Let's give a warm, normal welcome to Dr. Donald Abrams.
Thank you. It's a pleasure to be here, and I welcome all of you, particularly all my panelists who are not Northern Californians. As the local Northern Californian, I welcome you to Indian summer in Northern California, and the weather that we get in October is one of the reasons that we choose to live here. There are many others, as you know. So for those of you that don't know me, I just wanted to go back and give you a little bit of my history of involvement in this challenging field in medical research. I owe my place at the podium to two of my friends, Mary Rathbun and Rick Doblin. Yeah. Mary, who you may recall, otherwise known as Brownie Mary, was the volunteer of the year at our AIDS clinic at San Francisco General Hospital for 2 years in the early 1990s. Mary used to wheel patients to X-ray and take their prescriptions to the pharmacy, and she used to bake them brownies, and she was known as Brownie Mary. She baked these brownies for her kids, and at that time in HIV it was very disturbing. We had no treatments, patients died, and Brownie Mary's contributions were really legion. And I happened to be at the International AIDS Conference in Amsterdam, of all places, in 1992, and I glanced at CNN headline news and saw Brownie Mary being arrested in Sonoma for making marijuana brownies. And when I came back to San Francisco General, there was a letter from Rick Doblin, the founding president of MAPS, the Multidisciplinary Association for Psychedelic Studies, suggesting that a clinical trial demonstrating the medicinal benefits of cannabis come from Brownie Mary's institution, as if she were our dean. Well, in the early 1990s, there wasn't much going on in HIV research, which is what I was focusing on. So I picked up the gauntlet and began to try to do a clinical trial looking at cannabis in patients with the so-called HIV wasting syndrome, which was a very big problem in the early 90s in the Bay Area. Patients just became skeletal, looked like concentration camp victims, lost their appetite, and found benefit from smoking marijuana. At that time, and this was, remember, 92, we still had Bush 1. We were just transitioning to Clinton. We thought everything would be much better. Bush 1 closed the compassionate use program that was distributing cannabis for medicinal purposes to a handful of patients. And in the same year, 1992, dronabinol or Marinol, synthetic delta-9 THC, became available as a treatment for loss of appetite associated with the AIDS wasting syndrome. So everybody said, well, patients don't need marijuana because we have dronabinol or Marinol. Now, when you take the one active component out of a plant that has 400 other things that balance it, the yin and yang, you're sort of it's the Western pharmaceutically dominated paradigm that a plant is not a medicine, and that if we find the active agent, it's better. But the other agents in the plant are balancing the adverse effects of delta-9 THC. So, you know, that's one of the things I've learned in this 16 years that I've been doing this research. In any event, it was, as one can imagine, quite difficult in the early 90s to get the government to allow me to do an investigation on the medicinal benefits of smoked cannabis. And I finally learned from Alan Leshner, who at that time was the director of NIDA, that NIDA, the National Institute on Drug Abuse, has a congressional mandate that they can only supply marijuana for clinical trials that look at it as a substance of abuse. He said, Donald, we are the National Institute on Drug Abuse, not for drug abuse. So we cannot study marijuana as a treatment for a medical condition. So in 1997, we received our first grant from the government to study cannabis in patients with HIV, taking the very potent new antiretroviral medicines, the protease inhibitors. These drugs are metabolized by the kidney, or by the liver, through the same system that metabolizes a number of other drugs and recreational substances. And there had been a case of a person dying from an overdose of ecstasy who was taking these protease inhibitors. So we wrote a clinical trial looking at the safety of smoked cannabis in patients taking these new potent HIV protease inhibitors. And the government liked that because we were looking at safety and potential toxicity. We weren't looking for effectiveness. And we did get an award of $1 million and received 1,400 of the government's finest cannabis cigarettes in 1997. And over the next 2 years, we conducted a clinical trial where we enrolled 67 people. For 25 days each, they were basically incarcerated in our General Clinical Research Center at San Francisco General Hospital. And we measured the impact of smoking cannabis 3 times a day, taking dronabinol 3 times a day, or dronabinol placebo, on the level of virus in their bloodstream, the measurement of the protease inhibitors in their bloodstream, and on their immune system. And we found basically that there was no detrimental effect on the virus, on the levels of protease inhibitors, and in fact there may have been a suggestion that there was improvement in the immune system, something that was quite surprising to everyone. So with that information that cannabis was safe, we were then fortunate to be here in California, where in those years of budget surplus, one of our heroes, State Senator John Vasconcellos, introduced a bill in the legislature that created the University of California Center for Medicinal Cannabis Research. This center's goal really was to investigate the potential medical effectiveness of cannabis in a number of conditions. And they had $3 million a year for 3 years to fund clinical trials. And NIDA worked it out, so as long as they weren't funding the studies, being the only legal source of cannabis for research, they would provide cannabis to studies that were otherwise funded. So the CMCR graciously funded my group to do 4 clinical trials. I just want to say that the 2 studies that we were funded to do in cancer patients both failed because we could not enroll cancer patients in cannabis studies. I'm an oncologist, and for me, this is really quite startling and disturbing, and I'll get back to that towards the end of my short remarks here.